Okay, welcome everybody. Thank you all for coming. For those of you who I don't know, I'm Sandro Galea. I have the privilege of serving as Dean of the School of Public Health here. This is one of our monthly public health fora, which is our premier academic event for the school, sort of a grand rounds for the School of Public Health. And what we do every month is invite a distinguished scholar to talk about her work or his work. And today we have really one of the leading scholars in her area, Professor Marcia Angell. So let me tell you a little bit about Professor Angell, and then I'll give some editorial comments. So by way of at least affiliation, she served for a long time as a member of the editorial staff of the New England Journal of Medicine, joining them in 1979, was executive editor in 1988, and became editor-in-chief in 1999. She is originally a graduate of Boston University School of Medicine, so she is one of our own. She has written books and articles on a wide range of topics, including The Truth About Drug Companies, How They Deceive Us and What We Can Do About It, which was also a bestseller. She has received really a range of dizzying array of honors. She's a member of the AAP, the NAM, she has the Alpha Omega National Honor Medical Society, and a fellow of the American Association for the Advancement of Science, was named one of the 25 most influential Americans, and has won the Polk Award for magazine reporting. So she has an extraordinarily distinguished CV. But from perhaps a little bit more of a personal note, Professor Angell is sort of one of my heroes. And I don't say that lightly. I say that because she is consistently, and has been for decades, one of the smartest, clearest writers out there on issues that affect health, and I think on issues that anybody who's interested in health in this country as well as around the world should care about. I find her writing clear and always provocative, and I always learn from reading her writing. And these days I read most of her writing in the New York Review, and every single time there is an article in the New York Review by her, I feel like it's like Christmas. I'm like, I can't wait to read it. And every single time I end up learning something and feeling just a little tiny bit smarter for having read it. So it's really an honor to have Marcia here with us. Marcia.
Thank you so much for those kind comments, Dean Galea. I am really honored to have been invited to give this lecture this afternoon and to have the chance to return to this campus. As the dean said, I graduated from BU, School of Medicine. Next year it will be 50 years since I graduated. And I was just looking out the window how different everything is now from the way it was when I first came here in 1963. As incidentally, one of maybe 6 or 7 women in a class of maybe 75. My first day at medical school, one of my fellow students said to me, and not pleasantly, he said, "Why don't you be a nurse?" So that's how it was in those days. It's very different now. I'm going to be talking with you today about what can charitably be described as the worst health care system in the advanced world, if judged by accessibility, quality, and costs. I'll discuss why it's so bad, the effects of the Affordable Care Act, also known as Obamacare, and finally, my own views of what reform should look like. And this should take me maybe half hour, 40 minutes max, and that should leave some time for discussion. I want to start by describing 3 features of our health system that distinguish it from every other health system in the advanced world, and that were unchanged by Obamacare. The first of these features is that the United States healthcare system is uniquely expensive and uniquely inflationary. Last year, we spent over $3 trillion, that's with a T, or $10,000 per person, man, woman, or child in this country on health care. Now, that's 2.5 times as much as the median expenditures for the 34 OECD countries. That's the club of rich nations. And these other 33 countries, they cluster fairly close together. I mean, some, like Switzerland, are more expensive than others, like the UK, but still they cluster fairly close together, whereas we are definitely an outlier, and the gap between us and the others is growing year by year. The second distinguishing feature is that we don't get our money's worth. By the usual measures of health outcome like life expectancy, infant and maternal mortality, immunization rates, preventable mortality, that's an important one, we actually rank below most of the other OECD countries. And contrary to popular belief, you often hear it implied that Americans are somehow more hungry for health care, more demanding. Contrary to that popular belief, we don't provide more basic services. We have fewer hospital beds per capita, fewer doctors, shorter hospital stays, and we see our doctors less often. For example, Canadians visit their doctors roughly twice as much as Americans do. But we do have many more tests and procedures, high technology tests and procedures, particularly those in freestanding for-profit ambulatory care centers, imaging centers in particular. We do many more of those, and the prices of those are much higher. Worst of all, we're the only wealthy nation that doesn't provide health care to all its citizens. Even after Obamacare, tens of millions of Americans remain uninsured, and most of the rest of us, whether we know it or not, are underinsured in the sense that we are not covered for all contingencies. So here we have a system that's outrageously expensive, yet inadequate and inequitable. The people without insurance tend to be poor people, minorities. So how can we explain this paradox? We spend more and we get less. Well, the only explanation is that there is something very inefficient about the way we deliver health care. And now I'm going to tell you what that is. The third distinguishing feature of our system is that we are the only market-based system among the OECD countries. And in fact, we don't have a system at all. It's a non-system. It's a hodgepodge of different commercial arrangements that exist more or less independently of one another, sometimes competing, sometimes duplicative, sometimes just going off in their own way. The other countries, in contrast, all have national health systems of one sort or another. Some are single-payer systems, true single-payer systems, which means that all of the health care funds are funneled through a single public agency that distributes and coordinates the resources. Some do have multiple payers, like we do with private payers, but the system is tightly regulated so that everyone is covered and prices and benefits are uniform, and in most cases, the care is provided in a nonprofit system. So even countries with multiple payers, like Switzerland, have a very different sort of system, which is universal and uniform. So why should a market-based system lead to high and rising costs? Because it certainly does. Why should that be? Well, in a sense, this is economics 101. Successful markets expand. That's what they do. Nobody says, oh, I want my revenues to decrease. That isn't what you do in a market. And this is a very successful market for lots of reasons, which we can talk about later. So it's a successful market, and every element in the market is trying to do more business, not less business. I heard the Brigham and Women's advertising last Christmas. Get your husband a total body, or your wife, a total body CT scan, because it would give him the Christmas present of peace of mind. Now, this is an organization that wants more business, not less business. So when we say we would like to decrease what the U.S. spends on health care, that makes no sense in a market-based system, since all of these many elements are trying to grow, not trying to shrink. So we'll come back to that a little bit later. It's useful to think of the health system in two parts: the financing system, how we pay for health care, and the delivery system, how we provide health care. These can be considered quite separately. Financing for most Americans is through hundreds of private investor-owned insurance companies with premiums paid by employers or by individuals, or both. The best way for all of these insurance companies to compete with one another, that is to keep their premiums down to get more business, but to keep their profits up because they're investor-owned, the best way to compete is by stinting on services. The aim, in a nutshell, is to attract the affluent and healthy and avoid the poor and sick. That's what they do, if they can. We have the only healthcare system in the advanced world that is built on dodging sick people. We treat sick people like a hot potato, and we shunt them off for somebody else to take care of. The private insurance industry has very high overhead costs, about 14% now, used to be much higher than that, about 14%, which covers profits, very large executive salaries, and also the cost of avoiding sick people, because that takes some skill to market that accordingly. And then they have the companies that they do business with. There are all sorts of satellite industries, billing agencies, marketing agencies, and so forth, who also have their own profits and overhead and so forth. So it's a very expensive inflationary system. And then the providers who deal with the insurance industry have reciprocal costs, hospitals, doctors' offices, because they have to deal with many different insurers, with many different regulations. So that's the financing system. Now let's look at the delivery system. That is, the hospitals and outpatient facilities that actually provide the care. Many of these are for profit, but even the ostensibly nonprofits behave in much the same way. We can see that very well here in Boston. Doctors are paid mainly fee-for-service, and in this country, the fees are greatly skewed to reward specialists doing high-tech tests and procedures. And so not surprisingly, we have an awful lot of specialists doing an awful lot of high-tech tests and procedures. The skewing has made doctors as a profession, very different from one another. The specialists can make an awful lot of money, whereas primary care doctors often don't make enough, in my opinion. So the way the fee-for-service works, I think the best way to illustrate that is my favorite medical joke, which really has to do with a veterinarian. And it seems that a woman comes into the vet's office carrying her pet duck, totally limp. She's really upset. "Save my duck," she says to the vet. The vet puts the duck on the examining table and examines it and says, "Madam, I'm afraid that your duck is dead. You have a dead duck here." And she begins to wail and says, well, maybe it's just in a coma. I mean, maybe something could be done about this. Maybe there's a second opinion. And he says, well, okay. And he opens a door to an adjoining room, and a Labrador retriever comes in. And the dog kind of sits on its haunches and puts its front paws on the table, walks around the table, sniffs at the duck, sits back on his haunches, shakes his head sadly at the vet, and runs out of the room again. Out of the same room comes a cat. Cat comes running out, leaps up on the table, walks around the duck, sniffs at the duck, sits back on his haunches, and shakes his head sadly at the vet. The vet says, "Madam, I'm afraid that your duck is indeed dead." So she pulls herself together and she says, well, okay, what do I owe you for that? And the vet said, well, that'll be $500. And she says, $500 just to tell me that my duck is dead? And he said, oh, no. He said, that part was just $20. But you throw in the lab test and the CAT scan. And he said, he says it all adds up. So that is the story of our healthcare system. Now, in my judgment, the widespread overuse of technology is an even bigger cause of waste than the private insurance industry, and that means a lot of waste. When Barack Obama became president, he put reform of the healthcare system at the top of his domestic agenda. He favored a single-payer system when he was a senator in Illinois. But he decided that once he was president, he couldn't afford to alienate the health industry, mainly the private insurers and the pharmaceutical industry. So he launched his reform effort in 2009 with a White House media event that featured spokespersons for the health insurance and pharmaceutical industries. Remember, big pictures, they were all together. They pledged their support to Obama in reforming the system, but not for nothing. There was a price. And here were the conditions. For the insurance industry, Obama said, yes, we will have a mandate that will require people who do not have employer-based insurance or who are not covered by their employers, we will have a mandate that they will have to purchase private insurance for whatever you guys want to charge. So that was pretty good. That would mean a few million new customers. And for the pharmaceutical industry, he pulled back from his position on two laws that as a candidate he had pledged to overturn. And one of those was the law that prohibits Americans from importing cheaper drugs from Canada and Europe. And he had campaigned to overturn this law, and he then changed his mind in return for the support of the pharmaceutical industry. And there's a part of Medicare Part D, the Medicare drug benefit. There's a provision in this law that says that Medicare may not bargain for lower prices with the drug companies. And he said he was going to try to repeal that part of Medicare Part D. And he backed down on that for the pharmaceutical industry. So that was the deal. Obamacare was enacted a year later in March of 2010, 6 years ago. What were the main features? Now, you'll be happy to know I'm not going to go through all the Byzantine terms of Obamacare, but these were the three main features. One, big employers would be encouraged to offer health insurance to their workers or fined if they didn't. And small employers, those with fewer than 50 workers, would be encouraged to offer health insurance by being subsidized a little if they would do that. So that was the first thing, employers. Try to increase employer-covered insurance. The second major point is that Medicaid, and that's the federal state program for poor people, which the states more or less would parcel out as they wanted to. The second deal was that all states would increase Medicaid so that anyone earning less than 133% of the federal poverty level would be covered by Medicaid. And the federal government would pay 100% of that cost for the first 3 years. So Medicaid would be expanded, and it was thought that this would cover an additional 16 million people. Then the third was the mandate to purchase commercial insurance. And that was thought to cover another 16 million people. That was the idea. And so anyone who didn't have government coverage or employer coverage or wasn't so wealthy they could pay out of pocket would then have to buy commercial insurance. But the deal was that there would be government insurance exchanges online. And these people could go online, they could find a menu of plans that would meet a bare minimum that the government established. They could have some advantages of economies of scale because there'd be a lot of people using these exchanges. And if they had earnings of between 133% and 400% of the federal poverty level, they could get government subsidies. So these were the three things: employers, Medicaid, and the mandate. Now, Obamacare also curbed some of the worst abuses of the insurance industry. For example, the insurance industry was no longer permitted to refuse coverage to somebody because of a, quote, pre-existing condition, or drop them if they had the temerity to actually get sick, which they used to be able to do. So the plan did curb some of those abuses. But interestingly, insurers were permitted to charge 3 times as much for older people as for younger people. So if you were 60 years old, you might pay 3 times as much as a 27-year-old would pay. And it seems to me that probably age is the most important pre-existing condition of them all. But that is in Obamacare. And there were other protections too. So how would Obamacare be paid for? Well, here and there, a little bit here, a little bit there. There would be an increase in payroll taxes for families that earned more than $250,000 a year. There would be a 3.8% tax on unearned income like dividends or capital gains. There would be originally unspecified reductions in Medicare payments to hospitals and other facilities, a variety of fees on health industry companies. They would cut back on the overpayments to the Medicare Advantage plans. These are private plans for Medicare recipients, and they were paid on average 14% more for their enrollees as the same people would cost in the traditional Medicare. So they were being grossly overpaid, so Obamacare was going to cut back on that. So here and there. At the time, the Congressional Budget Office, the CBO, estimated the costs over 10 years and said it would be budget neutral. It would not cost any more. But this is important to recognize. When the CBO looks at the cost of a plan, it's only looking at the cost to the federal government. It does not look at the cost in premiums, out-of-pocket costs, only the cost to the federal government, and that's all the CBO looked at. Nor did, in this case, did it take account of likely inflation. That was not a part of what they were doing. So that's Obamacare. So since then, in the 6 years, what's happened? Well, it came before the Supreme Court twice. The first time was in 2010, and the issue was the mandate. Can you force people to buy a commercial product? And quite to some people's surprise, the Supreme Court says, yes, we don't consider that forcing people to buy something. We consider that a tax. And so it's okay. the mandate went through. But then the second time the Supreme Court considered it, it was about the Medicaid part. The fact that the states would all have to cover everybody making less than 133% of the poverty level if they wanted to keep their Medicaid program. And there the Supreme Court says, no, you don't get to do that. And so far, 19 states have refused to expand their Medicaid, even though the federal government would pay for it. These are states with Republican governments, and they've just said, no, they're not going to expand it. Medicare Advantage plans are still overpaid. There have been delays in implementation for both businesses and individuals. And the costs have gone up in an utterly predictable way. And I'll come back to that in a minute. An underappreciated problem with Obamacare is its Rube Goldberg-like complexity. Both its costs and benefits are derived from many different sources, and the interlocking parts don't always fit together. For example, most notably, in states, the 19 states that chose not to expand Medicaid, you have this situation in which very poor people, people earning less than 133% of the poverty level, have no insurance. Whereas those who are earning somewhat more, between 133 and 400%, are eligible to purchase subsidized insurance on the government exchanges. So these are interlocking parts that certainly don't fit together. The complexity also causes the diversion of health dollars to large bureaucracies to implement, administer, and regulate the system. One study showed that new administrative costs constituted 1/3 of the federal government's expenditures for Obamacare last year. So here's where we stand. In 2010, when Obamacare became law, 50 million Americans, or 16%, hang on to the 16% figure, 16% were without health insurance. The U.S. was then spending $2.6 trillion per year on health care, or $8,400 per person. Now, after implementation of Obamacare, more Americans are indeed insured. Still, about 29 million, or 9%, your second figure was 16%, now it's 9%, remain uninsured today. And after a brief lull during the recession, $1 billion more on health care last year than when Obamacare was implemented or was adopted, 600 billion more, while insuring only an additional 7% of Americans, the difference between the 16% and the 9%. This comes to a whopping $30 million for each person newly insured. Now, that doesn't seem like much of a bargain to me, particularly if costs continue to grow at the current rate. And the problem is that the underlying factors that cause our health system to be so expensive and inflationary in the first place were left largely untouched by Obamacare. The system remains in the hands of investor-owned private insurance companies, drug companies, and profit-oriented providers that can charge whatever the market will bear. And in healthcare, for various reasons, the market will bear much more than in other sectors of the economy. Moreover, these industries are consolidating, a trend spurred on by Obamacare, so that they behave more like oligopolies than competitive businesses. Now, costs matter. Many people used to say, well, as long as we have more access, don't worry too much about costs. But costs do indeed matter. Expanding access to health care, as Obamacare does, is only half the job. The other half requires controlling costs so that the system can be sustained. Already we can see many signs that Obamacare is unraveling because it lacks effective cost controls. The clearest sign is that insurance doesn't provide the coverage it once did. Many employers now cap their contributions to their workers, forcing employees to pay for premium increases out of pocket. They bear the inflation. It's just a set contribution to the employer. Co-payments and deductibles are also increasing, with the average deductible for covered employees having risen nearly 70% since Obamacare's passage. Low-income Americans who buy insurance on the government exchanges often find that even though they're technically insured and may even receive subsidies, they can't afford to use the insurance because of deductibles that may be many thousands of dollars. They just can't use the insurance that they have. Moreover, insurance premiums on the exchanges, and as we've all heard in the last couple of days, are projected to increase next year an average of 25% in 2017, and some much more. And some large insurers, United Healthcare and Humana and Aetna, are pulling out of the Obamacare market altogether in large parts of the country. So for 20% of Americans, if they go to the exchanges, there's only one insurer on them. They have no choice. Thus, even as access to health insurance has increased, thanks to Obamacare, underinsurance is growing. The system is being hollowed out. And health insurance is not the same as health care. If you take nothing else away from this lecture, I hope you will take that away. You can be insured and still not have health care, not be able to get it. Unless we're willing to see Obamacare collapse of its own weight and health care become a luxury for those who can afford it, we need to find a better solution. The best, maybe the only solution, is to adopt a national health program analogous to those in every other advanced country. In all of them, no one is left out, and the government regulates benefits and prices in one way or another, including the prices of prescription drugs. We could adopt such a system in the U.S. by extending Medicare to everyone and converting our mainly profit-oriented delivery system to nonprofit status. Medicare, after all, is a single-payer program for those over age 65. It's government-financed but privately delivered and has much lower overhead costs than private insurers, only about 2%. Everyone who's eligible receives the same package of benefits. You can't charge 85-year-olds more than 65-year-olds. You can't drop them if they get sick. So everyone gets the same package. Extending its advantages to all Americans would be the simplest, most efficient way to achieve universal care. But having a nonprofit delivery system would be an essential part of this reform, since the overuse of tests and procedures by the profit-oriented providers probably adds even more unnecessary costs to the system than the investor-owned insurance companies. Even though Medicare is a single-payer system, it uses the same providers as the private sector does, and the same profit-oriented providers. Paying for a single-payer program would require an increase in taxes, perhaps an earmarked progressive income tax for the purpose. But that increase would be offset by the elimination of premiums and out-of-pocket costs, and inflation would be slowed. With time, the new system would be much less expensive than the current system. And one great advantage is that employers would no longer provide health insurance. Since they wouldn't be saddled with high health costs for their employees, American businesses would be more competitive in global markets. Moreover, these businesses would be more likely to hire new employees since they wouldn't have to give them health insurance, and that's quite an expense. To be sure, within the health industry, there would be unemployment. People would lose their jobs in the private health insurance industry. But this might be offset by increased employment in other sectors of the economy, at least to some extent it would be. Hillary Clinton is now reviving the notion of a public option, which was dropped like a hot potato in 2009 because the insurance industry didn't like it. Now, her public option would enable people over the age of 55 to choose to enroll in Medicare early. While that proposal sounds good, I think it has two fatal flaws. The first is that sicker people would probably choose to enroll in Medicare, leaving the relatively healthy and younger older people for the private insurance industry, which would woo them, try to get the younger, healthier seniors, people over 55, to sign up in the private industry. This is the kind of cherry picking we now see in the Medicare Advantage plan, so we have experience with this sort of thing. They try to attract only the healthiest beneficiaries and leave the sickest for traditional Medicare, and I'm afraid that would happen with a public option. And then yet again, the government would be left subsidizing private insurance companies. And second, a public option would be just one more add-on in an already hopelessly fragmented and complicated system. And I'd like to see a simpler system, not a more complicated system. Instead, what we need to do is either convert to a single-payer system for everyone or implement it one decade at a time, beginning by lowering the age of Medicare eligibility from 65 to 55. Now, that's not the same thing as an option. It would not be an option. It would be automatic coverage for everyone in that age group so that there could be no cherry picking, as Medicare is now automatic for people over 65. That would still leave many of the inefficiencies in our current system unaddressed, but it would prevent cherry picking. So what is the fate of Obamacare? I'm finally washing up here, the fate of Obamacare. When Obamacare was enacted in 2010, it was generally heralded as the most important piece of social legislation since Medicare. 6 years later, can we still say that? Or is New York Times columnist David Brooks closer to the mark when in a column last month he referred to, quote, incredible shrinking Obamacare, close quotes, incredible shrinking. He pronounced it in that column only a modest add-on to the pre-existing system, not much. I'm afraid he was largely right. Obamacare is indeed unraveling, and the increasing out-of-pocket costs probably contribute to our growing middle-class sense of insecurity. But unfortunately, I don't see a solution on the horizon because Congress, or at least the House, is likely to remain Republican. So even if Clinton is elected, absolutely nothing will be done to expand coverage or diminish the profiteering within the system. Nothing major, nothing minor, nothing wholesale, nothing incremental, nothing at all. If Obama was facing implacable refusal to do anything, you can only imagine what Hillary will face with a Republican House. If Trump is elected, of course, there will, of course, be plenty of legislation, but none of it good. So what I've tried to do here is to outline the best way to achieve the most desirable outcome, so that in the future, when political conditions are more favorable, we'll have a roadmap for where we want to go and how to get there and what to avoid. I devoutly hope we won't have to wait too much longer. Thank you very much, and I'll take any questions and discussion. George.
Thank you for that. That was a terrific, if a little depressing, summary of our current system.
I don't think you need me to get depressed. Just pick up the newspaper.
One group you didn't mention at all, or if you did, I missed it, are physicians. And physicians used to run the healthcare system, and physicians used to like it a lot. Are physicians totally marginalized now? Are they not going to be, can't they change the system if they all got together? Or?
Well, let me first say that there's no such thing as an average physician anymore. I think my brother once said to me, the average person has one ovary and one testicle, but you've never met such a person. I have not met the average physician. We have, I think 70% of our physicians are specialists, and particularly certain specialists, cardiologists, gastroenterologists. They do have a lot of clout. And they make an enormous amount of money. But then if you look at the other extreme, pediatricians, psychiatrists, primary care doctors, they're having a hard time now. And they have almost no power. So when you talk about the doctors, as we said at the beginning when I said 50 years since I graduated, I've been around for a long time. And doctors used to kind of run the show. The AMA, everybody had to belong to the AMA, or all doctors, and the trade group was very, very strong. Doctors had a good deal of autonomy. They didn't work for anybody else except themselves, trying to either make money or save money. And then when HMOs came along, and this would have been maybe the early 80s, they were going to be working for companies. But since they had all been the smartest little kids in 5th grade, they thought they could make it work for them. And it turned out that the profession was to some extent taken over by business interests, the companies that own the HMOs. And I think that doctors are still, in one way or another, now working either to make money or save money for someone else. The hospitals, the big hospital conglomerates, are buying up physicians and, getting the referrals, and the physicians are dancing to their tune. So the short answer is physicians are working for somebody else now, to a large extent.
Quick question, John Woodson. Thank you very much for that very comprehensive kind of review of all of the sort of Gordian knot of factors that have gone into making the healthcare system the way it is. A question, what is your prediction of what's going to happen to the next administration if they don't deal with these issues? So one way of thinking about it is we wait until there is political will, but that's nowhere on the horizon. But yet there are a lot of economic issues and insurance issues that are going to collide.
Yes,
that's going to create a real situation for the next administration.
Terrific question, and one I wish I could answer, but let me make just a couple of comments. When I said that a Republican House was going to do nothing for a Democratic president, the only thing that could make them budge, because Congress, by and large, works for the people who pay them. The people who pay them are the lobbyists and big industry. The only thing that can override that is a huge popular sentiment. And the only thing members of Congress need more than money from lobbyists is votes. So if they found that continuing the way they're doing cost them votes, then they would change. They would do whatever they'd have to do. And that's one reason I was making the point that even though a single-payer system sounds just politically off the table, so is anything else off the table, even the incremental things. And yet the single-payer system, the public could get behind that. They can't get behind anything any more complicated than that. And the kinds of marginal changes that are so complicated, you can't have the kind of public outcry. That's a long introduction. Now, what's going to happen? You already see in a lot of the Trump supporters, people who are economically squeezed, who feel that their prospects are going down. They're already, in some sense, picking up their pitchforks and marching. And I worry if we continue to head toward a sort of a health system in which a lot of people do without altogether because they can't pay the premiums and deductibles. That's a terrible situation. That's a third world situation.
If I could have just one brief follow-up on
Yeah.
that point. So the number one reason for bankruptcy in recent years has been healthcare expenses.
Right.
So where do you see the role of the activated consumer in solving this issue? So patient groups.
Yeah, I don't think that there is much they can do. I truly don't think there's much they can do except get angry, and I think that's what we're seeing now. And so I don't know what will happen, but what I see in this country is that gap, that inequality growing and growing and growing, and the people who feel in most jeopardy getting angrier and angrier. And that's scary. That's scary. Yes.
So thank you. That was terrific. I feel even more depressed than George after that. So you used a phrase in your presentation. You said, for entirely predictable reasons. This is where Obamacare ended up. So may I push you on the predictability and on the crystal ball? So if I understand correctly, we're heading in a period where the Republicans, if they're in the administration, will do things that are sort of mostly destroying Obamacare without any particular solution in place. Mm-hmm. While the Democrats will, for reasons of party allegiance, try to tinker around the edges with Obamacare. And neither of those two are real solutions. Mm-hmm. So what happens? So what is going to happen in the next 10 to 20 years? Implicit in your response to Dr. Woodson's comments are that we're going to have more and more public unrest,
Yes.
which might result in pitchforks and torches and bad stuff. Is that what's going to happen? Is health going to be become a catalyst for true transformative popular anger that pushes something? Is that the only solution?
I think health is, I mean, as was said, that is the major cause of bankruptcy. And I think that the problems in middle-class families' coverage of their health will be a big part of their unhappiness. And a lot of optimists hope that Bernie Sanders made Hillary move left, that she will be more concerned about these things, that Elizabeth Warren will keep her feet to the fire, that there may be some kind of a resurgence of left-wing policies, but you still have that Republican House. And since we don't have a parliamentary system, you can have divided government, and it's almost impossible to do anything major in a divided government now with the polarization of ideology. So I'm pessimistic. If you and George can cheer me up, try it. But I would like to see the country pulled together more and the inequality blunted, and the inequality gets worse and worse.
I've heard two things, and I just wanted to ask you what you think. One is that the 25% increase in premiums was predicted by the Congressional Budget Office, and that one of the reasons is because the penalties for not signing up is just not great enough to encourage younger people who are healthy to do so. So is this sort of behavioral economics perspective on healthcare true?
Well, I don't know what the CBO said about it, but it's predictable for the reasons I said. It kept in place the insurance industry, and it kept in place the profit-oriented providers. So it was predictable in that sense. People were breathing a premature sigh of relief during the recession because they said, look, healthcare costs have eased off. But it was predictable that after the recession, they would take off again. Also, I think the insurers were trying to get customers, so they were offering unrealistically low prices for them to get customers, and then they did a bait and switch. I mean, they suddenly went up. So I think all of that was going to happen. Now, it is said that it's because the fines for particularly young, healthy people to buy insurance are not sufficiently high, and that the subsidies are not sufficiently high. That may be so, but that does not seem the answer to try to squeeze blood out of a turnip. I would rather change the system than ask particularly young people who already are having a lot of economic problems to pay bigger fines for not buying bad health insurance. So I don't think that's the answer. Kick them around a little bit.
Hello.
Yes.
Great talk, thank you. So we're a country of large businesses, and the insurance industry is one of those large businesses. Yes. The businesses that you spoke of quickly in the talk are ones that you think are putting off some of these costs onto their employees, and thereby crippling those employees while protecting themselves. Why hasn't the drive for cost containment really come out of the business world? There are lots of big businesses in this world which are becoming oligopolies. In many ways. So why hasn't there been a drive, a greater drive from that direction?
I think it's a kind of a primitive ideology that they come from a country in which the market is thought to be the solution for everything, and the system that requires them to buy expensive health insurance is what the market has coughed up. But if you look at some of our businesses that have national parts in Canada. For example, the motor industry. When there was some talk about Canada privatizing the western provinces, British Columbia and Alberta doing more privatization, the heads of General Motors, Ford in Canada wrote letters saying, no, we don't want this. While across the border, the same companies are going along with it. But they did not want any employer-based health insurance in Canada. They thought it was a very bad deal. I think that some businesses are beginning to see the advantage of going to single payer and getting out from under this. But, I mean, realizing that even though ideologically you can talk market, there are different markets, and the health market is different from the automobile market. And I think there's a slight bit of air between them now, that some of the businesses are realizing this is not a good deal. But I think it's ideology.
Thank you so much for being here today. So you talked about Medicare for All, which would cover many, many more people, but coverage is only part of the problem. And you touched on this a little bit, that having insurance coverage is wonderful, but it doesn't change access, and it doesn't change a lot of other things about cost or availability. So how do you see population health or public health becoming integrated into this new system to address some of these costs? Certainly not all of them are attributable to insurance.
Yes. Another good question. The reason Medicare alone for everyone would not solve all the problems is primarily because of the profit-oriented delivery system. So I would rule out profit-making on the backs of sick people, which when you think about it, if you came from Mars, you would say, this is a silly thing. Why should you pay twice? You pay for being sick and then you pay money for it besides. So that's the major thing. But in the delivery system, which should be a nonprofit delivery system, which most advanced countries have, it should incorporate, definitely, public health as a part of the nonprofit system. And public health is largely nonprofit now, as it is. I was telling Professor Annis a little while ago that I was on a program at the Aspen Institute last June, and we were talking about care for chronically ill people toward the end of life. And when we were, and not just, the hospice care for people who are going to die in 6 months, but frail people, people living on their own, but elderly. And all of this really was drawing on public health and social health, not just medicine, but people who could come into the home and help with a meal, or people who could set up some kind of system for these people. All of that would be part of a nonprofit system, of an efficient nonprofit system.
I'm going to stop us here so we have time for some informal exchange. Please join me in thanking Professor Angell.